Welcome back to the deep dive. Today we are taking a close look at cerebral palsy, or CP.
Right.
This is a condition that, for many of us, I think carries a really incomplete or even inaccurate picture.
hmm
So we're going to try to distill the clinical reality for you, define the condition, explore its surprising causes, and really understand the evolving challenges across a person's lifetime.
And that lifetime view is just so essential. When we talk about CP, the official definition is a great place to start.
Okay.
It describes a group of non-progressive disorders of movement and posture, and these lead to activity limitation, and they're caused by a disturbance in the developing fetal or infant brain.
Non-progressive. That's the word that immediately jumps out at me. It creates a kind of paradox.
It does.
If the injury to the brain is static, the damage itself doesn't get worse. Why is managing CP this ongoing lifelong challenge? Why the constant physical therapy and intervention?
That is the absolute core conflict that drives management. The underlying brain lesion is static, yes, but the effects it has on the rest of the body are profoundly dynamic.
Dynamic, okay.
The research is very clear here. If we delay or reduce treatment, the risk of secondary musculoskeletal or MSK and neuromotor impairments just increases significantly as the child grows and ages.
So the body grows around a static injury, and that growth itself creates new, often painful problems.
Precisely.
Okay, so let's establish the scope of this. How common is CP, and when does this foundational brain damage actually happen?
Well, CP is the most common physical disability in children. It affects about 2 to 2.5 children per 1,000 live births.
And what's really striking, based on our sources, is that this rate has stayed pretty much the same for the last 40 years.
It's incredible, isn't it? Despite all these immense medical advances in neonatal care, the needle just hasn't moved much.
That statistic is genuinely counterintuitive. We've seen huge leaps in saving high-risk babies.
We have.
So what does that unchanged rate tell us about the nature of the damage?
It suggests that the causes of CP are often much broader than the typical acute events we've learned to manage so well in the NICU.
Okay.
We see massive prevalence rates in high-risk groups. For instance, infants born highly premature, so less than 28 weeks gestation. Their CP rate is over 111 per 1,000 live births.
That confirms what you expect, right? Extreme prematurity, high risk. But this is where the data gets really interesting.
Absolutely. Because even though the risk is highest for those preterm infants, they only account for about 35% of all children who are ultimately diagnosed with CP.
Stop right there. So 2/3 of children with CP, 65%, are born outside that extreme prematurity bracket.
That's right.
That just completely challenges the common public understanding of the condition. So if it's not always extreme prematurity or some acute birth trauma, when is the developing brain most vulnerable?
The injury can occur across 3 major windows. There's antenatal, which is during pregnancy, perinatal, which is around the time of birth, or postnatal, in the first couple of years of life before the brain really matures.
And what does the imaging tell us about the breakdown?
Imaging usually attributes about 43% of cases to that perinatal window, 34% to antenatal, and only about 6% to postnatal causes.
And our sources have a key insight about that 65% group, the term born kids.
They do. Recent reports really highlight that for the majority of children born at term who later develop CP, the disorder can't reasonably be pinned just on a birth injury or classic oxygen deprivation during delivery.
So we need to look earlier. What are some of those major antenatal causes?
Sure. Antenatal factors can include things like maternal infection, brain malformation during development, genetic factors, and multiple births.
And for preterm infants?
For them, major risk factors are often brain insults, like an intraventricular hemorrhage that's bleeding into the ventricles, or periventricular leukomalacia, which is damage to the brain's white matter.
And thankfully, medical progress has chipped away at some of these risks over the decades.
It has, absolutely. We've nearly eradicated CP caused by Rh incompatibility through better testing and care.
Right.
We've reduced cases of kernicterus, that's brain damage from extremely high bilirubin, just by using specialized lights.
Yeah.
And there's huge promise in treatments like therapeutic head cooling for infants with severe hypoxic ischemic brain injury.
But even with all this progress, a definitive diagnosis in the first couple of years is still a huge challenge.
It's extremely difficult. The earliest neurological signs can be transient. They can come and go.
So that leads to a wait-and-see approach.
It often does, yeah, until a child is over 2. And that is such a major missed opportunity because early intervention during that critical window of brain plasticity is just it's essential.
That moves us perfectly from the when of the injury to how it actually presents. This is where classification comes in. How do clinicians categorize CP?
It's usually done based on two things. The type of movement, which kind of reflects where the injury is in the central nervous system,
Okay.
and the topographic distribution, which just describes what parts of the body are affected.
Let's start with movement types. What's the most common?
The spastic type is the vast majority. It's about 85% of cases. This involves damage to the motor cortex or the white matter paths.
And functionally, what does that look like?
It means increased muscle stiffness, restricted movement, and movement that often happens in these predictable synergistic patterns, not the smooth, isolated joint movements we use every day.
And then there are two less common but really challenging types.
Correct. We have dyskinetic CP, which affects maybe 5 to 10% of individuals. This is caused by damage to the basal ganglia, which is kind of our movement control center.
And this presents as difficulty holding the body still.
Exactly. The two major forms are dystonia, that's painful, involuntary muscle contractions that cause twisting and abnormal postures, and then athetosis, which is more of an uncontrolled writhing movement that gets worse when the person tries to move on purpose.
That sounds just exhausting to experience.
It is. The energy expenditure is massive. And then finally, we have ataxic CP, which involves the cerebellum,
The balance center.
the balance center. So the key features here are poor balance, uncoordinated movement, and real difficulty with timing and accuracy.
Okay, let's move to the second classification system. Topographic distribution, where it affects the body.
Right. The three main types are defined by which limbs are involved. Diplegia, that's 44% of cases, is where the legs are predominantly involved. The arms might be mildly affected or not at all.
Then there's hemiplegia.
Hemiplegia, 33% of cases. That involves the arm and leg on one side of the body. Of the spastic groups, this one tends to be the most functional.
And the most complex is quadriplegia.
Right, quadriplegia, which is about 6%, involves all four limbs. This is associated with the most significant restrictions in function. These individuals are often in the highest restriction levels on the functional scale we use.
Okay, let's dig into the immediate effects of that brain lesion, the primary impairments. We hear terms like spasticity and tone thrown around. What do we really need to know?
The most immediate consequences are spasticity and poor selective control.
Okay.
So spasticity is basically an abnormal rapid resistance when you try to move a limb passively. The technical reason is that the damage messes up the normal neural signals, and you get this simultaneous activation of opposing muscle groups.
So if I try to bend my elbow, my bicep and my tricep are firing at the same time, basically fighting each other.
Exactly that. That co-activation is why movement is so restricted, so inefficient, and why it requires such massive effort.
And this is linked to tone?
It is.
Sure.
It's linked to issues with tone, either extreme stiffness, which is hypertonia, or low-tone hypotonia. But the core problem really is that loss of selective control. It's the inability to just move one joint without a whole compensatory pattern kicking in.
And as we touched on, CP is a multi-system disorder. What are some of the associated non-motor impairments that make the challenge even greater?
This is such a critical point, and it often gets overlooked. These motor disorders are frequently accompanied by disturbances in sensation, cognition, and communication.
And the numbers are high.
Astonishingly high. Vision impairments in up to 71%, speech difficulties up to 81%, seizures up to 40%, and issues with feeding and swallowing in up to 86% of individuals.
Wow. I mean, think about the complexity that imposes on the care team. It's not just a physical therapist. It's a whole team.
A whole team. Occupational therapists, speech pathologists, ophthalmologists, neurologists, you name it.
There's a pattern here, right?
Yes. The greater the motor impairment, so the more severe the GMFCS level, which we'll get to, the greater the likelihood and complexity of all these associated cognitive and sensory issues. It's a cascade effect.
That brings us right to that tool, the Gross Motor Function Classification Scale, or GMFCS.
The GMFCS is essential. It gives clinicians and families a common language for prognosis and for planning interventions. It uses 5 levels based on functional abilities.
So level I is the least restricted.
Right. A child at level, I can walk without limitation. Maybe they just have a bit of trouble with more advanced skills, like running or jumping quickly.
And level V represents the other end of that spectrum.
Correct. A level V individual is typically transported in a manual wheelchair. Their self-mobility is severely limited, and they often need extensive physical support just to change their posture.
So the GMFCS doesn't just classify current function, it also helps predict the future. What do those developmental curves show us?
This is one of the most important findings from the research. While children generally gain motor skills rapidly in early childhood, those in the higher restriction levels, that's levels 3, 4, and V, they actually show a risk of motor regression later on.
Wait, motor regression, that's a powerful term, especially since we started by saying the brain lesion is non-progressive. Why would function get worse?
It's not the brain failing. It's the body wearing down under all that abnormal stress. The lack of selective control and the constant co-activation mean that as a child grows, the abnormal forces cause severe secondary musculoskeletal impairments.
Okay, let's talk about those secondary evolving impairments, because they sound like the root of the lifelong challenge.
They absolutely are. Due to the constant abnormal muscle pull, individuals develop contractures, so shortening of muscles and soft tissues, and significant muscle weakness.
And that leads to poor alignment.
Exactly. Poor biomechanical alignment, which results in bony and skeletal torsions in the femur, the tibia, and eventually the spine.
And this mechanical failure puts certain joints at extreme risk. I'm guessing the hips are a big one.
The hips are the big one. Because of those common abnormal leg postures, constant extension, adduction, internal rotation, the hip socket just isn't loaded correctly.
Which can lead to dislocation.
It increases the risk for hip displacement, subluxation, and full dislocation. Without proactive orthopedic monitoring, this leads to immense pain and a huge loss of function later in life.
And the strain is felt across other systems, too. I imagine pain and fatigue are huge factors.
Massive factors. Pain is a huge secondary issue. It stems from the MSK challenges, but also sometimes from chronic GI issues, like GRD. And on top of that, the high energy expenditure required for movement causes cardiopulmonary fatigue.
So just walking is like running a marathon for some.
For many individuals with CP, yeah. Even walking short distances requires an enormously higher heart rate than it would for someone without CP. The body is constantly fighting gravity in itself.
This just hammers home the need for a lifespan approach to care. So what's the overarching role of physical therapy through all these stages?
The role is to anticipate and minimize those secondary impairments to support functional activities and really to optimize participation in the world. It's a marathon, not a sprint, and the goals have to shift with age.
So let's look at early intervention. For infants.
In infancy, the focus is all about parent education, proper positioning, trying to prevent those early contractures, and fostering emerging motor skills, like postural control.
And getting them moving is key.
Critically important. We know that mobility, whether that's crawling, walking, or even using a power wheelchair, which can start as early as 14 months, has massive positive effects on cognition, socialization, and play skills.
And the orthopedic vigilance has to start early, too.
Yes. The standard is that children who can't walk 10 steps on their own by 30 months should start getting annual hip x-rays.
And for the more severe levels.
For children in GMFCS levels 4 and V, spine x-rays are necessary by age 5 because the risk of scoliosis and spinal deformity is so high.
As they move into school age, the focus shifts to efficiency and independence.
Right. This is when we have to reassess how rapid growth spurts have affected alignment and function. And given the fatigue issues, encouraging aerobic activities is vital for long-term health.
And the stats you found really show the reality of daily life.
They do. For kids aged 4 to 12 and levels 3 through V, 67% were pushed in a wheelchair just for moving around outdoors in their community. It really underscores the need for assistive tech and smart mobility planning.
And finally, the transition to adulthood, which presents the ultimate challenge as function can often decrease.
This stage demands so much proactive planning. You're addressing everything from living arrangements and personal management skills to higher education.
And the functional realities are pretty stark.
They are. One study showed that 75% of individuals were no longer walking by age 25, largely due to that chronic fatigue and movement inefficiency.
3/4 of people stopping ambulation by their mid-20s. That means the focus of care shifts entirely.
Absolutely. The clinical focus moves from maximizing walking to managing secondary pain, which often comes from early onset degenerative arthritis in joints that have been loaded abnormally for decades.
So it becomes about quality of life and participation.
Exactly. The shift requires comprehensive planning for seated mobility and pain management to maintain quality of life and, most importantly, participation.
And that concept of participation, that seems to be the guiding light through all of this, isn't it?
It is the ultimate goal.
Participation is what improves self-esteem, creates social opportunities, and combats isolation and depression.
And what drives participation?
Well, walking is consistently the most significant factor associated with the ability to participate.
Yeah.
But, and this is important, the sources remind us that we can't ignore the other two major predictors: hand function and cognition.
That brings us full circle, really, back to the holistic nature of this condition.
It does.
We started with a contradiction. A static brain lesion causing these dynamic, life-altering challenges across a whole lifespan, influencing everything from muscle tone to social opportunity.
And that's the final, crucial takeaway. Since CP involves neurological, sensory, and cognitive systems, we have to ask a bigger question. How might our intervention priorities need to change if we acknowledge that success isn't just measured in steps taken, but in social engagement and cognitive development?
So if participation is linked to walking, hand function, and cognition,
Then focusing purely on motor skills, without integrating cognitive and communicative goals, might be missing the wider opportunity to maximize a person's ability to truly live a full life in their community.
a profound thought on maximizing life, not just movement. Thank you for guiding us through this deep dive.